So it's a great honor to introduce Oliver Adunka, who is at The Ohio State University, running the Neurotology, Otology program there. And he's going to talk to us today on intraoperative real-time electrocochleography during cochlear implants. So thanks for joining us and taking the time out to give us some insight. Thank you.
Yeah. Well, thanks, Bill, for having me. Thank you to all your partners and to Laura for setting it up. Really great honor to give this talk. Some of you, or most of you, probably know that I've been working on this topic for quite some time. Let me advance the slide here. So these are my disclosures. As you know, Craig and I have been working on this. Craig, obviously, most of you guys are well aware with him, was a fellow in the mid-90s. I think after you, Bill, right? He was a year or two after you, I assume.
Yeah. Craig was actually my medical student at the University of Florida when we were in Florida together.
Oh, I forgot that. Yeah, you were a UF resident. Yeah, exactly.
Yeah, we go way back.
Obviously, you guys go way back. Doug is a scientist at UNC. Obviously, during my time when Craig and I were partners at UNC, we did a lot of this work together and formed a company that actually did arise out of this work and was ultimately the patent, or two patents were actually ultimately sub-licensed to Advanced Bionics. So that's my disclosure. As you know, many of the two other companies have the system basically implemented as well. Today, since I've worked with Advanced Bionics, that's what I'm going to be talking about. But again, Medel as well as Cochlear have FDA-approved versions of this. And again, I will be disclosing some of these newer parts of the ECOG system that are not yet FDA approved. So really, we thought about cochlear implantation as a pretty sophisticated procedure, but really the electrode neural interface isn't that sophisticated because we just stick the electrode in the cochlea without any feedback, really. So we felt that we could customize electrode insertions and fit the insertion to the cochlea. And therefore we account for, size differences that have been described, trauma, residual hearing. And we felt that folks just need a long enough electrode to cover what needs to be covered. And then we record as we insert the electrode. And again, then customize the insertion based on physiology instead of just, inserting all the way up to the hub. And there's several clinical scenarios possible. Obviously, we'll talk about those later. But we felt that, the surgeon could actually use this as a tool to improve electrode insertion, and therefore cochlear implantation. And really, why not? Because all cochlear implants have the ability to record. We call it NRT, NRI, or ART, depending on the manufacturer. However, that's an electric stimulus, right? The implant also can be active during insertion process. We just don't hook it up as we insert it, but you could theoretically activate the implant via the external magnet and record not electrically evoked, but acoustically evoked parameters. And these may demonstrate either damage or the relationship of the electrode to functional dead regions in the cochlea. And really, those were sort of our initial thoughts of what we wanted to do, right? I came from hearing preservation cochlear implantation, and I really just was interested in improving hearing preservation rates. And the fact that we didn't understand, or still probably don't understand, what's going on inside the cochlea during and especially after we place an implant. So we wanted to generate a smarter insertion process using real-time feedback and really empower the surgeon to make decisions that are based on physiology rather than anatomy or when the electrode's all the way in. And this feedback should allow us to gain insights on electrode positioning as well as the functional status of the cochlea. And since we're using an implant, we didn't want to have to deal with some other kind of electrode montage. We just wanted to use the implant because that goes in anyways. And this would really be something that could potentially be adapted. And really, I'll talk about this in a second. We started in 2005. That's when I came to UNC, and we subsequently did some patients, but it was very clear that we had no idea what we were looking at. Especially I didn't come from electrophysiology, so I really had to learn a lot of these concepts. We did establish an animal model, and that's where Dr. Fitzpatrick, I mentioned earlier, came into the picture. I'll talk about this a little bit. Ultimately translated it to humans, or with folks who get a cochlear implant in the operating room. We felt it was a good opportunity to learn. And then from 2015 and on, the device companies started to implement this in their devices. So this is the patient from 2005. It was really a case report of a patient with auditory neuropathy, so a child with auditory neuropathy who had, obviously here we see the intraop images here. So facial recess, obviously drilling off the niche, and then electrode insertion, and the corresponding electrophysiology. And those were far field ABRs, so classic ABRs with just surface electrodes as we're used to. And we can see the absence of distal waveforms, and inverting wave here as the cochlear microphonic potential, right? And as we drilled, there's obviously not a whole lot happens. We see the rarefaction condensation, but here we only plotted one of them. And we did an opening of the cochlea that didn't really do anything. And then while we inserted the electrode, you can see that the amplitude was decreasing of the cochlear microphonic, and it remained recordable, but it was certainly the amplitude wasn't as good as before. So we thought, wow, there's probably something there we can use. Auditory neuropathy obviously is a very a unique case where we have a large cochlear microphonic, but what happens in folks who get a cochlear implant? So we use this concept of electrocochleography, which is really the electrode being closer to the cochlea, and the classic definition that is on the promontory on the tympanic membrane. And we use these stimulus-evoked cochlear potentials. And really, we isolate these potentials to the cochlea simply by proximity. So we place the electrode really close to it. And our idea was that cochlear implant candidates probably don't have a lot of ECOG potentials, right? But so we need to be really close to the source generators, aka the hair cells. So we really thought we needed to have intracochlear electrocochleography, right? Which hadn't been sort of described until then. And as we all know, electrocochleography for Meniere's disease and endolymphatic high drops, we use the SPAP ratio of 0.45 typically, and larger to diagnose Meniere's disease. I personally don't use it clinically. I know it's a common board question, but that's what we all know electrocochleography for. When we switch the stimulus of electrocochleography from a click stimulus to a tone burst, we can obtain an ongoing response. So this is the stimulus up top. So we play a tone for about 10 to 20 milliseconds, and then we record the ECOG response. And again, these are examples from where the electrode was placed at the round window. And we record the electrocochleography response from that electrode. And we can see in response to the stimulus, we have a little latency, and we can see the cochlear microphonic potential, right? And those are basically hair cells, outer hair cells predominantly, the opening and closing of channels in outer hair cells. So basically the outer hair cells, they follow the envelope of the stimulus. And then we have the summating potential, right? That's the offset here to the baseline, the summating potential. It's also a hair cell potential, primarily an inner hair cell potential. So it's a distortion potential. And that's what we feel, or what's believed that in Meniere's disease would correlate to the stretching of the basal membrane and the endolymphatic high drops that's associated with that. And then we have the cap, again, for the classic electrocochleography recording would be the AP. So that would be the AP-SP ratio. And the AP is the compound action potential, basically on the onset of the stimulus, when all the auditory hair cells as well as neurons are not receiving any input, so they're dormant. And once we discharge all of them, we get this compound action potential at the onset, but also the offset of the stimulus. It's much smaller at the offset. And so we have these four potential, again, the CM, the cap, the summating potential, and the auditory nerve. Neurophonic, which I haven't said, is to very low stimuli, less than 1,000 hertz. We usually don't get into refractory times of the auditory neurons, and we can get a phase-locked response of the auditory nerve. We don't really use the ANN for a clinical electrocochleography, but it's an interesting stimulus to learn from. If we don't have a cap, but we can still identify some nerve, we call it the nerve, that would be the ANN. Interesting, that seems to be a surrogate marker for hidden hearing loss that's been recently described. So this is a picture of a gerbil. You can see the animal here. That's a younger version of myself. There's a microscope, obviously, and there's several micro manipulators going into the cochlea or the inner ear. Here we can see that electrode, that's the recording electrode. And in this picture, we have larger electrodes. So we started off with tungsten rod electrodes where we wanted to introduce trauma, and then switched over to celastic type electrodes that we all are familiar with from cochlear implantation. And you can see here the gerbil bulla, that's the tympanic annulus, the backside of it. So this is a posterior incision. Stapes, beautiful, is the pedial that's the round window. Niche here, and that's the round window. That's the lateral semicircular canal back here. And you can see that large bull that the gerbil has. So the cochlea basically goes straight ahead in this picture. And this is the montage that I'll show the picture from the sound booth from where we have a micro endoscope. We lit up the cochlea. It's a really neat kind of instrument. It's a flexible fiber optic micro endoscope. It sits in the round window niche here. It's slightly different angle. Then we made a laser cochleostomy here, and we can monitor how the tungsten rod goes in the cochlea. And we have the basal membrane here is the darker structure, the OSL, and the spiral lamina. You can see that the endoscope is pretty grainy, but you can see what's going on. Usually the resolution of this is about 800 pixel. And as we touch the basal membrane, what we can see is that our amplitude of signal amplitude actually decreases. So this is the raw signal. This is the CM extracted as a fast Fourier transformation. And you can see the cap here too. Interesting how the CM as the hair cell potential would really decrease. And when we plot them over time down here, we can see that the CM continues to recover as we back up the electrode, and we basically touch the basal membrane, back it up, touch it, back it up. And ultimately we see a decline in the CM, and ultimately actually even the cap, but the cap being much more robust to these changes, probably because it's from a much larger area of the cochlea, right? So we thought, well, there's probably potential in it. Those are only about 10 averaging cycles, right? When we look at an ABR, we have at least 500 averaging cycles, and therefore we have the delay that arises from, that's why it takes 45 minutes or so or an hour to get a threshold ABR for both ears. But here it's obviously, we don't have that time in the operating room. So we needed something that's immediate and shows us what's going on right then. Now, this is the corresponding histology where we can see those penetrations of the basal membrane here. These are, again, organ chordae explants here. We can see those holes generated by the electrode touching the basal membrane. And of course, this was in normal hearing gerbils. We felt that, well, it's all it's all fun and nice, but we need situations where we do have a high frequency hearing losses. So I only have a slide for this, but it took us like a year and a half to to make a reliable noise-induced hearing loss model in gerbils. It ended up being a lot of work, but by changing the cutoff frequency of the noise exposure, and we built a separate chamber too, we can change the configuration of hearing loss on the gerbil. And we can see as we lay up the organ of Corti, we can see that we have preserved apical structures, and we have this transition zone, and then the base is really wiped out. Yeah, so that was a nice model. Again, I didn't realize at the time how much work it actually was, but it turned out to be nice. But what I meant to say is that in these hearing loss configurations, we still had very robust electrocochleography responses. What we then, and what we're currently actually doing 10 years later, is we're working on longitudinal penetrations and multi-frequency stimulation. So you can see here, this was 1,000 hertz to 16,000 hertz. Again, the gerbil here is well above 32,000 hertz. So it has a lot, very good high frequency hearing, but also good low frequency hearing. That's why we use it for this. And you can see that that we get different ECOG insertion curves based on the stimulus frequency used. And we saw this again in the gerbil, sort of discarded it over, but now coming back to it as we are developing multi-frequency stimulation for electrocochleography in greater detail. So here's a nice picture of how this was obtained with just this electrode. Obviously, you can see it's only one electrode contact here in a celastic body, and we can sort of go along the longitudinal axis of scala tympani here. But we did from 2011, I believe, on forward is we also went to the operating room. So Doug, who was an animal researcher, or still is, I should say, we dragged him into the operating room and used a biologics machine, an ABR machine. And during cochlear implantation, you can see the pin as you know, pinned forward with an IO-band drape. And this is the sound tube, just the one you're familiar with from ABRs. And used the facial nerve probe, you know, that we stimulate the facial nerve. We retro-engineered that and used it as a recording probe. It fits nicely in the round window niche. And we recorded, you know, during cochlear implantation, just before we opened the round window, we took 5 minutes and did some ECOG recordings. So this is extra cochlea. We're still not in the cochlea, but we recorded, and we felt we got pretty good signals. And again, those are all cochlear implant recipients with obviously a lot of hearing loss. But you can see that we got a cap here. We got a cochlear microphonic. You see this distortion here. That's either hair cell distortion, but more likely there's an auditory nerve neurophonic part of this. Once we stop the stimulus, we can see the cochlear amplifier here in the far end of the signal. And when we extract the frequency spectra with a fast Fourier transformation, this is a 500 hertz stimulus at 90 dB NHL. We can see that there's a big maximum with 500 hertz, which is the cochlear microphonic. And we can see a smaller maximum at twice the stimulus frequency, which is the auditory nerve neurophonic. So we felt like a lot of these cochlear implant patients had the potential to be monitored using this kind of technology. And back then we felt, well, we still were interested in hearing preservation. I mean, that was my initial interest. That's where I came from. Scala location ultimately tied into that pretty heavily because we wanted the electrodes to remain in scala tympani. There are a lot of at the time there are a lot of literature on scala dislocation, so scala vestibular insertions with especially with preformed electrodes, and what also came into play with tip fold-over detection. And simply because I feel like an X-ray in the operating room is just really cumbersome. and I wanted something else that tells me whether or not that tip is folded over. It's a low incidence, but still, we felt if we want to detect it, it's a good one to detect inside the operating room. And other things that we thought could potentially be possible with this was to predict the audiogram, so measure hearing, basically, predicting CI performance. And ultimately, with the insertion monitor, we felt that we can improve surgical consistency, especially for parts of the world and the country where cochlear implants are not as common as for larger centers. It may help in CI fitting as well. So what have we learned, really? And let me go through that list briefly. And again, I've divided it up into extracochlear EKG. That's where we started in humans. And then we compare between the recording sites, and then we move to intracochlear EKG, which was our initial idea. So extracochlear EKG, really, what is the likelihood of meaningful EKG recordings? And I remember I gave this talk before we actually did human experiments, and Joe Miller from the University of Michigan said, "Oh, it's fascinating, but all your patients are deaf, you won't get anything." So, and that obviously was concerning for us. So we looked at our EKG recordings, and now these are I would say just 123 and 41 children, but we've done over 600 patients now, combined at UNC, WashU, and Ohio State. And the data hold true, namely that about 95% of patients, again, all comers, have meaningful EKG responses. And I mean that about 1 microvolt or better at 500 hertz, right? You can see the percent of subject with a significant response here. 500 hertz being the best, 250 pretty good as well, but not as good as 500, and then 750, 1,000, and then obviously with high frequency hearing loss and typical configurations of CI candidates, we can see that the likelihood of getting higher frequency information obviously drops dramatically. Again, those are children, those are adults. In adults, interestingly, 500 is far better than in children. But we felt this data was very encouraging, namely that a lot of our patients had a response that at the round window that we could potentially work with. And then one of the things we looked at as well was, and it sort of was a pet project that arose from all this, was to look at electrocochleography and post-op CI performance, which, as we all know, it's very hard to predict post-op cochlear implant performance in kids as well as adults. And at this point, the R-square, so the most meaningful correlation, is with duration of deafness, but that only predicts about 20% of the variance in adult cochlear implant performance. So if we plotted the electrocochleography total response, and we created this artificial measure, basically bunched up all the frequencies and amplitudes and created this artificial measure of the total response, it's basically the magnitude of the EKG response to be obtained at the round window. And we correlate that with CNC scores here. We got an R-square of 0.49. So again, this the simple EKG TR at the round window just before I insert the electrode accounted for about half the variance seen in adult cochlear implant recipients. And in children, this was lower. It was only about 0.36. But again, there was also a better correlation in children where residual hearing seems to predict a lot of their performance. But again, EKG may be a better measure to predict that. Once we get rid of outliers and other things, we can have an adjusted R-square when we factor age in of 0.57. So almost 60% of the variance can be predicted just with this electrocochleography total response measure. So, and again, we were sort of perplexed by it because there are a lot of studies, obviously, that are it remains unclear why cochlear implants actually work that well in some people and not that well in some other people. And we do feel like that poor performers are a real, issue in cochlear implantation, and really want to make sure that we have a better way to predict cochlear health prior to cochlear implantation, or even during cochlear implantation. It would be great to have that before, obviously, to explain cochlear implant performance, and especially low performers. There's obviously some other factors that are mediated with via cognitive abilities, but again, cochlear health seems to be a main factor. In their non-neural patterns, obviously, they're all some patients we can detect with electrocochleography that some patients have some incomplete neuropathies, have hidden, with really hidden hearing losses. So we're part on that spectrum, and there's some mapping problems. Again, you've probably seen the Vanderbilt stuff with turning off electrodes. We really haven't been successful with that, but obviously there's some inter-individual differences in why people have hearing loss that are really not accounted for in this, right? But we feel like dissecting these reasons really relies, obviously on more work, but will be critical down the road, and our ability and help with our ability to predict cochlear implant performance. So we felt overall that ECOG may be a good way to predict performance, to help us understand what's actually going on with cochlear implant performance. But again, we're still extracochlear. We still haven't actually gone inside scala tympani. And then again, since this was the initial idea, we wanted to compare extra and intracochlear recording sites. So this was complicated, right? Because we needed to attach this this recording electrode. We mounted it to one of the retractors. This is the cochlear implant electrode here, and we can see round window niche is drilled. We can see the round window here with the crista fenestra. We have the promontory, and this is our recording electrode. And as we compare intra and extracochlear, so just sticking the electrode through the round window, making a little slit with a Rosen needle at the round window, inserting the electrode just a few millimeters, we can see the 2 to 6 time increase in signal amplitude, again, at the basal part of the cochlea. And this is the cochlear microphonic. We can see here extracochlear in the black line, and intracochlear is the blue line. And this is the fast Fourier transformation. So again, this was published a while back, but we felt that intracochlear will allow us for a better signal. Better signal is important because us as surgeons, we're all impatient. We don't want to wait forever to have the signal evolve so we can make a decision. So we felt the real-time aspect is really critical. So the better the signal, the more the more reliable the real-time information really is. What we've subsequently done, since we have an intracochlear electrode, it's called a cochlear implant, we felt that we need to set up this whole paradigm via the cochlear implant. And so we retro-engineered the cochlear implant, turned off the electric stimulation for NRI, NRT, or ART, and really made the cochlear implant a recording device that triggers an acoustic stimulator that's in the ear canal. And the early days, we did that with our own rigged up system that we hauled to the operating room. But now we can actually use the cochlear implant, and actually even via the radio frequency link. And this has been approved in AB, and Cochlear has a version, Medel as well, that all work the similar way. We again partners with AB. So that's who we worked with, and this is the setup we use. Basically, we basically play a hearing test during electrode insertion, right? We trigger the acoustic stimulation. As we insert the electrode, we record via the device, and we have a graphical as well as a acoustic display of what we're actually looking at in terms of the signal amplitude. So we basically plot the signal amplitude as we insert the device. So the first thing before I talk about the actual insertion, what also was sort of a side project that came out of this is how to predict threshold, basically do an audiogram with intracochlear electrocochleography. And at the end of the surgery, what we usually do, we obtain multiple recordings. It takes about a little less than a minute usually, and we correlate that with the noise floor, and therefore we can predict. You can see that here. We can see where the noise floor and the signal amplitude would intersect, and we can calculate a threshold based on that. And we actually validated that with post-op audiograms and the behavioral audiogram and versus the ECG audiogram, and it was within 5 decibels. So we felt it was a very accurate recording of hearing, at least as we insert the electrode. Obviously, there's some other factors that happen in the operating room to post-operatively that we currently can't really account for. But these are all obtained in the same post-operative setting here. This is some more data. So it should indicate, as we use it in the operating room, right, it just indicates the hearing right then, almost like the pre-op hearing. It may be useful in the post-op setting, as we, if you have children and otherwise really difficult to test patients where you want to just determine some post-op threshold. But also it takes a minute rather than, the usual time it takes to obtain behavioral audiograms, which certainly 20 minutes or more. So, and this is what it looks like in the Advanced Bionics software. Basically, it spits out this as part of the report cut after insertion. It basically tells you how you did as a surgeon to insert the electrode. Again, post-op hearing may be affected otherwise, obviously, but again, this is what you would get in the operating room, right? So you could talk to the family and just say, hey, from what we did today, we seemed like we were able to preserve some hearing. Obviously, some other factors at play, but we felt it was a useful tool. And finishing up here with the ECG changes as we insert the electrode, and that obviously was the initial goal of this whole research, was to define trauma, hearing preservation, etc., and what we can learn from that. So the current protocol is that we have continuous recording. So again, we continue to play a 500 hertz tone at 90 dB NHL. And we plot the curve that correlates with the amplitude of the signal that we get. And we capture events as we go in. Usually it takes a second person. Sometimes we ask one of our audiologists to do it. Sometimes we ask one of the scrub techs or the circulator primarily to do it. And then we provide verbal feedback to the surgeon. That's how we've done it. But there's also an acoustic stimulus, almost like a truck backing up, and sort of a warning signal that changes with proximity. And then we have post-insertion measures. So once the electrode is fully inserted, we usually perform a frequency sweep for thresholds. So we get the audiogram basically and the electrode sweeps, and we look at an EFI, what we call, which is basically that we look at maps for electric field measurement. Some people call it transimpedance matrix, to look for tip fold-over. And we repeat that 500 hertz stimulation while we coil the electrode when we close. So we usually have at least 10 minutes during closing where we can obtain more data. And as we insert the electrodes, so this was a study we did with Vanderbilt, where you can see these patterns, right? Where we have this, what we call a type 1 pattern, where phase doesn't change. So we looked at that as well. But in dark here is the actual ECG amplitude. So in this case, you would see that it rises up as we insert the electrode throughout scala tympani, which is very common, right? Usually there's not a lot of hair cells in the base, but as we approach the middle turn, patients will have more hair cells in that area. So the signal amplitude rises accordingly, and then it stays up pretty much. There's a drop of less than 30 dB, 30%, apologize. And we view this as a positive response, likely associated with hearing preservation. This would be a type 2 where we see this phase change, right, with a drop in signal amplitude. That actually may be a non-traumatic electrode where we just move past the characteristic frequency, and the type 3 where we have this drop, but a small change in phase, which would be associated with a traumatic dislocation basically of the electrode into a scale of vestibuli. And we had in this study a sensitivity of 100%. It wasn't very specific at 77%. Positive predictive value was 54%, and negative predictive value was 100%. So there's some information embedded in this. We don't have a perfect understanding of what's going on, but certainly something that we can learn more from. So the escalating amplitudes with the depth of insertion basically indicates a proximity to sources, to source generators, again, more likely associated with residual hearing or residual hair cells in the middle turn. It drops may or may not be reversible. So it went from like this 10-second or 30-second electrode insertion to multiple minutes, where we try to optimize trajectories, insertion depth, etc. And can we use it to avoid translocations? It's really unclear at this point. There's a clinical trial, so hopefully we can understand this better down the road. And there's some intra-op and post-insertion maneuvers. They correlate with the pre-op audiogram. So there's a recent study from the Cochlear system that showed a significant correlation with ECOG patterns and post-op hearing preservation at 1 year. So not just immediately, but really sort of in the medium term here. We do find that intra-op recorded signals correlate less with the post-op audiogram. There's some correlation again, as I mentioned, but obviously there's some post-op changes that happen after we close that are not fully understood. And these phase changes often indicate a scale translocation as we combine phase into this, right? And one of the things that we've sort of worked on is the connection at the ear, because oftentimes when you put the Weedlander retractor in, you may pinch off that sound tube, and they're very pinchable, I should say, because we use that to obviously do a no sound run, where we basically put a mosquito across it to avoid sound going in. But again, it's absolutely critical. So the one we worked on with AB is very sturdy, and it's harder to crimp off. Plus, it comes in sterilely, so you don't have to exclude the ear canal from your surgical prep. You still can. So again, sound delivery is key. It needs to be clinically simple and actionable. The interface was really critical, and it was interesting to, I obviously came from the science, and that what drove me to do this project. But it was interesting how the engineers got involved, and it had to be clinically adaptable. And that's why we really took out a lot of the science and created algorithms to make it clinically applicable. Yeah, and it's clear that the speed of insertion also matters quite dramatically. It's a little more difficult with pre-curved electrodes, especially if you use a 632, for example. That becomes a little more difficult. There's still biological responses and changes that happen post-operatively, as we discussed just a minute ago. And there seems to be a hearing preservation benefit. Again, we had in our AP trial, we get a benefit that was not statistically significant, but again, the Australian group just got a significant hearing preservation benefit after a year. So there seems to be some value in this. So, and these are some other pictures from the system, where we can see here really low amplitude. So these are ones where it's interesting what patterns you can distinguish between folks who have a wiped out base, and then hair cells come in the middle turn. This is the electrode sweep associated with that. This is a drop without recovery. We can see here, there's something happening here. It's even hard to speculate on what exactly happened. So obviously there's more work that we need to do. And this is a late drop where we pass the characteristic frequency. So since we usually stimulate with 500 hertz as indicated up here, this likely is that we just moved beyond that, which is associated here with that electrode sweep at the end of the insertion. And these are hair cell patches that can happen, right? Again, we use phase as well in the new iteration of this. It's not yet FDA approved, but we're working towards that. And these insertion grafts, these are events that, you know, whoever runs the system on the tablet can take notes and annotations with it. Obviously, this will be a very advantageous type 1 insertion. What we've been working on is to use multiple frequencies. Actually submitted an R01 for animal experiments for this, where we use multiple frequencies simultaneously. So this way we hope to hone in on where the electrode exactly is, where we need to be. My ultimate goal was to have like a kind of a speedometer where we can see the electrode tip is at that corresponding frequency to really use Greenwood's map. But again, as part of a physiologic measure that also accounts for some acoustic remapping that happens with hearing loss inside the cochlea. So multi-frequency EKG, I feel like is the next thing that we need to figure out here. Still a lot of work to be done, and we can incorporate the multi-frequency stimulation in the report card, right? We have 500, 1,000, 2,000, and 4,000 hertz here with different frequency maxima across the electrode. So theoretically, this could be used for mapping a cochlear implant as well. So in summary, it's a complex signal. It seems feasible to at least use it as an insertion monitor in most patients, which is really one of the most surprising things about this project. Intracochlear signals are better, and the further you go intracochlear, even the better are the signals. It seems to predict variance in performance with the cochlear implant, so it would be great to have some preoperative way to determine that. We have the threshold frequency series as a way to plot an audiogram, and we have to really enhance our understanding about insertion patterns to really be able to optimize insertions as surgeons. So we need to understand when we look at this or we hear the acoustic signal, what exactly happens inside the cochlea. So we're still working on that. There seems to be some correlations, but again, there's still a lot of things to be ironed out, right? There's some correlations with hearing preservation, as I mentioned previously. Scale location, we feel like there's a really good way to detect it, quite reliable, and tip fold over as well via the transimpedance matrix and other measures we've employed here. So future directions really that the device implementations continue to be better. I think a lot of it relies on the chip that's actually part of the implant and what the sampling rate of that chip is. So I know that I believe all three manufacturers are working on this. Multi-frequency stimulation, obviously I'm biased with that, but that seems to be the new frontier. And again, we can also use not just multi-frequency stimulation, we can multi-electrode recordings. So we can have a whole matrix of what happens within the cochlea as the chips of the implants improve, allow us to just obtain more data. And again, there's the radio frequency link, the RF link through the skin is another bottleneck in this. I currently have a clinical trial. It's a UO1 clinical trial with where we try to determine electrocochleography and subsequent value of hearing preservation. It's with these 7 centers in the eastern part of the United States or Midwest, and we basically randomize patients, EIS candidates, to either monitor the conventional insertions and then determine the hearing preservation benefit in a different aim. So that's what we're about to start enrollment in this, but we're very excited to get some more randomized data into electrocochleography. I think that's all I had. Want to acknowledge the multiple contributors. Again, those are more than 10 years of animal experiments. Again, I'm not at UNC anymore, obviously, but Doug's still there, and that's where a lot of the animal work still happens. Greg's at WashU, so we all still collaborate. You can see the Vanderbilt group has really been very instrumental in moving this forward. So acknowledge Rob and Brendan and others. And on the right-hand side, those are medical students basically who all took a year off and worked with us in the lab for a prolonged period of time on a lot of these animal experiments. Again, that's all I had. Really appreciate you having me today. It was a pleasure being here.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.